First of all, thank you for having me here. When I get invited to these forums, sometimes I'm not really sure what the audience would be or kind of what I should talk about. But Mr. Martinez, I don't know if you kind of read the newspaper, they have the experts in health, and he's been one of the ones they've been quoting about health reform in the San Diego Union. To me, he's one of the few that makes sense when I read his comments. But let me just set the stage here about health reform in general and what does it mean for our community. Through the years, this has really become a passion of mine. I had one time given a talk, it was actually in another country, and after the talk, an individual came up to me, Dr. Hood, I heard what you said, it was very interesting, but you in America have such wonderful health care. The blacks have, do so well. And I said, well, in a sense that is true, but there is something in me that has never allowed me to feel satisfied being the best second-class citizen of the world. And if you look at the health data in this country, that's what it says. Let's don't even talk about racism, let's just talk about science. And if we go back 400 years, 200 years, 100 years, and today, there have always been what we call health disparities. Really, years ago they called it health inequities, because that's really what it is. And what it states is when you look at certain ethnic groups, their health status is worse when you compare it to the majority. It's always existed. There have been some improvements, but even in the 21st century, health inequities still exist. And if we look at the times in history that we have had health reform, it has definitely benefited the minority populations. But it's also benefited everybody. So it's kind of like you come up with a program that says we need health reform that's going to improve health, and it happens, and the boat rises for everybody. But the way health reform in the past has taken place and improved health for everybody, it still kept a well second-class health citizen because it didn't affect disparities. And so I think this time we should realize that whatever happens in Washington, and I think something's going to happen, I'm a CNN nut and TV nut and watch it all the time, and it's like a ping pong ball, who's going to win, who's on first, who's on second, the no option, your option, my option. I mean, what's going to happen? I am convinced that the American people, who I don't always think make wise decisions, are not dumb enough not to let something happen. We cannot go forward with this. I see it every day in my practice. And we're not talking about whether you're poor or black or white. It is not working for everybody. So something's going to happen. And one of the things I challenge people with, and especially our community with, is why are we sitting on the sideline? We should not only be fighting for health reform, we should be anticipating that health reform will take place. And specifically, how will that affect our community? What can we do so that not only do we rise with the boat, but that we begin to see the narrowing and elimination of what we call health inequities? Because I guarantee you, everything coming out of Washington is not going to make that happen unless we do. what am I talking about? We can go back, first of all, to me, the arguments against health reform, I shake my head. All other systems in the industrialized system, I think, have a much better system than us. And in science says, well, you look at the outcomes. The longevity is higher, the chronic diseases are better, the infant mortalities are better as compared to us, yet we spend 2 to 3 times as much. Something's wrong. And so when we go through this health reform, people say, well, how are we going to pay for it? And now, don't take this personal, but I say the same idiots in this country that are paying the $2.5 million now. Us. We're already paying for it. We don't want to be taxed. Yet, when my insurance went up 15% last time, that wasn't a tax. And that was the best I could do. And now that my wife recently diagnosed with breast cancer, those bills are coming in, and the co-pays, and what's not covered. If I didn't have a job, I'd be in serious trouble. And I got patients who, one day I'm seeing them with insurance, next day they come in, well, doc, I wasn't able to get my medication because I lost my insurance, etc. Happens every day. How can we accept such a system? So we're already paying. So any change in the system compared to what we have has got to be better than, it's got to improve where we're going. One of the things I have talked about a lot is improving. There are 3 main issues that will improve somebody's health status. It's called access, lifestyle, and how you treat it in the system, how you navigate the system. Those of us who have the access, those of us who try to live a healthy lifestyle, and those of us who learn how to navigate the system do much better than those that don't. And some of the factors that influence that are your income, money, education. And when you look at the various populations that have the most difficulty in all 3 areas, it's in the minority communities. So as we talk about health reform, we should be thinking, should we have employer mandates? That's a good question. Should everybody be taxed? That's a good question. Should we have single payer? Should we have a public option? Let me put my feelings on the table. I was one of the few physicians years ago, before physicians were on board with this. I strongly believed in single payer. Today, I still believe in single payer. But I'm pragmatic.
You know, you hear that term single payer. I'm not sure that I really know what that means.
Okay, let me make it very simple. Single payer is just who's paying for health care. Mm-hmm. In the single payer mantra, it is, most folks interpret that as a government payer system. Just think of it as Medicare as a single payer. Okay. So everybody would get Medicare. Right now, Medicare is just for seniors. Single payer would be that everybody would be eligible for Medicare. To me, every other system has shown, and then there's hybrids of that. You know, you got France, Italy, Germany. They don't have total single payer. They have some form of government plan, but they also have private. And I really think that that's probably what we should have here, so folks would have options. But the single payer just means there's one paying entity. Okay. And say that's the government. Why does that make sense? I believe in being an entrepreneur. I've actually owned a small health plan. I own IPA. I own my own business. okay? And most folks will tell you, and I hope nobody here, if you work for a health plan, I'm not talking about you personally, but I don't know what a health plan does. It's like a broker, okay? And how did this system develop in this country? I mean, health plans aren't evil people. It was a system that developed in this country after the war, kind of out of necessity. That's kind of what we chose. It came into a business, and some of my best friends work for them. They do some good things, but on a capitalistic basis, as far as money, provider that gives the health care and the patient, it is more cost efficient to do it without that system. Just pure and simple economics. And so that's it. The issue is that because the system has been here so long, most folks feel that it's not going to go away. It's too much investment into it. So therefore, we had Conyers. This was a healthcare forum that took place right here in southeast San Diego in July, before you started hearing about healthcare forums. And we invited John Conyers, who has, for the past 10 years, in Congress, a single-payer plan that he's been pushing. And the purpose was really just to get folks educated about healthcare reform, what's happening back in Washington, answering questions like, what is single payer? What is the benefit from it? If not single payer, then what? What I am now convinced of is that some type of healthcare reform is going to take place. And I think where most of the folks are, everybody's thinking of, well, how is it going to affect me personally? And I'm hoping we can move to, how is it going to affect our community? Because most of us who can think of how is it going to affect us individually usually are the ones that have a business, have a job, have access to, wondering about what our co-pays would be, and is it going to be cheaper, is it not going to be cheaper? But then the individuals out there, a lot of the patients that I take care of, there's nobody speaking for them. And that's where what I've been doing with Mr. Martinez. Mr. Martinez comes in. For years, he and I have worked together and talked about different plans. We have anticipated that some type of health care reform would take place. We have put in a grant, applied for a grant for the California endowment, and specifically it is a year-and-a-half grant to do strategic planning in southeast San Diego and central south area to develop a strategic plan as to what is the best health care delivery for this area. And using the information that we get from that to make recommendations to increase the medical manpower, because we know that that's an issue, to improve the quality. How do we measure quality? And specifically from this area, what are the best ways to do that? How do we bring about collaboration? I'm in private practice. He runs a community clinic. Not many folks in the country see collaboration between private practice, community clinics. How can we synergize that? And I think it's these types of innovative ideas that we need to start thinking about for our community, as far as whatever type of health care reform comes, that we're in a position to take advantage of it so that it benefits our community. And I'm going to end by stating there's something I talk about called health disparities math. Healthy People 2010 was a program under Clinton in which the then Surgeon General Thatcher came up with a plan to eliminate health disparities by 2010. Won't happen, but it was a good idea. And he had two goals: improve quality of life overall and eliminate health disparities. He separated them because of how I started out my conversation. What he was saying is, whatever programs we have in the past have always, improved access, getting more folks insurance. Just because we have insurance doesn't mean you're going to improve quality. So giving access, giving everybody insurance is only part of it. But if we don't focus on what happens after that, we will miss the boat on eliminating disparities. And that's what we should be thinking about. Thank you. Am I to introduce Mr. Martinez? Okay. First of all, Mr. Ed Martinez, he's Chief Executive of the San Ysidro Health Center. He's had over 30 years of healthcare management experience, including administration of 2 acute hospital centers and a multi-special medical group. Mr. Martinez earned his master's in public health, hospital administration, received master's and bachelor's degree in public administration from San Diego State University. In September 1998, Mr. Martinez became CEO of San Ysidro Health Center. It is the largest, it is a large federally qualified health center adjacent to the U.S.-Mexican border. Its patient population consists of 50,000 South County residents. Each year, about 150 service encounters in the area of primary care. His expertise is in healthcare management, federally qualified health centers, health of South San Diego County residents, uninsured, underinsured patients in South San Diego County, and health of Hispanics in South San Diego County. Mr. Ed Martinez.
Can you hear me with the lapel mic? Or is this better? This is better, okay. Well, thank you, Dr. Hood, and thank you all for the invitation. It's quite an honor to be with you this morning. There is a lot going on here in San Diego and at the state, which is not really good news. It's really, where are they coming from? A year and a half ago, they were talking about universal coverage and really doing a lot in the area of primary care, but they're not talking that way now. They're just talking the opposite, slash and burn. The good news is coming from Washington, D.C. And Dr. Hood and I, for 20 years now, have been talking together and planning and trying to come up with ways, innovative ways to really, at the community level, make a difference in how we are able to deliver care that improves the quality of life. I understand we go till 9 o'clock? Okay, I'm going to keep my comments about 7-8 minutes, and then we'll open up to questions and answers. Let me get... In Washington, D.C., what we're seeing now is really, I think, a once-in-a-lifetime opportunity to improve how we run, how we finance, how we organize our healthcare system. Why it's so important for our community is that, like Dr. Hood said, something's going to happen probably before the end of the year. And we know that they're going to expand health insurance coverage. There are 47 million uninsured Americans right now. In California, it's 6.6 million. In San Diego County, there's close to 400,000 to 500,000, probably about 400,000 residents without insurance. In Massachusetts, 2 years ago, when the state went to a universal coverage program, 2/3 of their 600,000 enrolled in the new state-funded program that is federally supported, about 50%. So if 2/3 of our 400,000 uninsured residents today get insurance tomorrow, what's going to happen? That's what Dr. Hood and I have been talking about. Where are they going to go for care, and where do they live? What's the most convenient place for them to access care? Dr. Hood said it's not enough to have insurance, and he's right on. There are many patients that have Medicare and Medi-Cal, but they can't access care because the closest provider is too far away. They don't have a car. It takes a half a day to get there by bus. The provider possibly doesn't understand their social cultural background. It's not of the same ethnicity. They don't feel comfortable. They feel unsafe. They feel threatened. They don't go there, even though they have insurance. So coverage of insurance is just sort of the first part of it. Access to a provider that you can trust, that's convenient, is the second part of it. And then once you have access, then you have to be able to utilize the program in an effective manner. That's why it's so important when you talk about disparities. Disparities are typically in insurance coverage. Well, we should be able to handle that with health reform because more people will have insurance. There are also disparities in access. And if we can do a good job here in the community and improving access through our reinvestment, our rebuilding of our safety net, then that's going to have dramatic effect on the utilization. And if patients that have insurance can see a doctor or a nurse practitioner or a physician's assistant, the outcomes will be better. So the disparities now that we look at in terms of outcomes, health status, people of color die earlier. They have more chronic conditions that go without treatment. They spend more time in the emergency room. They spend more time in the ICU. They're readmitted to the hospital more. And that's because they've not had health insurance. And we're all afraid to charge up the bills for something if you don't have a source to pay for it. So people don't go to the ER until they're really sick. That's why so many are admitted. And that's why so many have to stay in the hospital for 5, 10, 15 days. And it drives the whole thing about people going bankrupt because they can't pay the bills. So I was asked a question at this editorial board by the San Diego Union, why do we need health reform? And one of my comments was that because it's really an issue of social injustice. Social justice requires that we treat everyone equally. Everyone should have a right. Who in this room would not say, well, that family, those children there, they shouldn't have the best health care just like us, just like our kids. I have 2 girls that are grown up, and I have 2 grandsons. And I look at them and I say, thank God that I was able to provide insurance. And I would not tolerate for a second that other families, other children would not be able to have the same thing. That's just a human right. So we have to make that difference. So if we have more health insurance, more coverage, what can we do in the community? Well, I think it's a tremendous opportunity for all of us sitting around this table. Dr. Hood and I think, are working on a program, proposals to different sources to build up our safety net. Now, what is a safety net? The safety net is the system of care for those without insurance, those who have maybe insurance but high co-pays, they're underinsured, they're just afraid to go to the doctor because they can't pay for it. Their insurance doesn't cover it. So what do we need to do? We need, number one, Dr. Hood and his colleagues have committed the last 30 to 40 years to serve this community. Their personal professional lives have been here in the community. Well, they have to sometime think about retirement. They have to look at the next phase of their professional, personal life. So what are we as a community going to do? Who's going to take their place? There's not a lot of doctors out there lining up to come into a primary care practice. And why is that? It's because our system right now, started with Medicare and Medicaid, they pay a certain way. And that payment structure is the more you do, the more you get. So specialists who can do multiple procedures are able to generate more income. Family doctors, internists who have patients that have chronic conditions don't require multiple procedures. They require time in explaining how you can manage your chronic condition like diabetes, how you manage your time over time. And it takes a team. And the doctor can't do it by himself. He needs a nurse, he needs an educator, he needs a patient navigator, a coordinator to do that. And right now the payment from Medicare, and particularly Medi-Cal, they don't pay for that. It's not a priority. So we're trying to convince people it's important to look at the payment structure has to be different. It has to be based on if we are able to enroll, like Dr. Hood said he has an IPA, 10,000 enrollees from this community. We're saying we should be budgeted, not so much every time we treat the patient, but we should have a budget that's based on taking care of the 10,000 people over a year. and it should be based on what it takes to provide the best comprehensive care. And at the end of the year, if we could meet quality benchmarks, the patients actually do improve, and there's savings from our care, then we should be able, as a provider group, to share in those savings. So it's a real drastic change in the way the payment is structured and the way care is delivered. That takes a lot of talking and convincing, but there are some. There's H.R. 3200. It's a House bill. It does have in it one provision calls for setting up what they call an accountable care organization, an ACO, which is really a partnership at the community level between doctors, whomever, doctors, community clinics, hospitals that have a mission to serve the community. The health department is another key player in this collaboration. So in San Diego, we have a number of good things. We have a number of things to be proud of. The health department has recently organized and managed a care initiative for 3,500 patients that are on CMS, a county care program for the medically indigent, for patients that have diabetes and hypertension. These patients typically do not have medical homes or doctors they go to. They often wait till they're real sick and they go to the ER and they cycle through. They're very costly for the county to manage. So the county organized a program, contracted with clinics and some doctors, and now the documentation after 2 years shows that this approach has really made a difference in not only the care, the quality care to the patients, but to the cost. So that's wonderful news. It's a partnership that's working, that's making a difference, and it's quantifiable. And if we can explain that to the people in Washington as well as the state, Sacramento, then we as a community will be in a good position to attract grants and other resources to try pilot programs. None of this is going to work with the providers, the doctors, the clinics, and the hospitals, and the health department just by themselves. It's not going to work. That's why we have this one pamphlet here, which is really, this is taken from New York City Health Department. It's called Taking Care of Yourself, but in New York City it's called Take Care New York. This is a health disparities initiative that they released to everyone in the city of New York. It's based on scientific evidence, what is called best practices, that if an individual and their family can practice these measures, then it's going to make a real difference in their health outcomes and health status. The first one is have a medical home, have a primary care doctor that you can go to when you should go to the doctor on a regular basis just to be checked up. Particularly if you're over the age of 50, you have to have certain kinds of exam tests to preclude you from just knowing if you have a deadly disease such as cancer or diabetes. To be tobacco-free. That's very important. Being free of tobacco and alcohol is a major plus in your quality of life over the long period. So these are sort of health promotion lifestyle measures that we can all take without a hospital or a clinic backing us up. But you have to have basically in the community an infrastructure of physicians, private doctors, health centers, clinics with partnerships that we can provide the testing that's necessary, the health education, and for those patients, many of our patients in our communities, the African American and Latino community, they have high rates of diabetes, cardiovascular disease, hypertension. We need to increase the level of awareness, the education as to what causes these conditions, and if you have them, how can you manage them better? How can you have preventive measures, interventions, so that your condition can be improved? Some conditions like Alzheimer's, you can't cure them. You can delay them. You can take medications. You can get support. So it's very important that you have a workforce, an infrastructure in the community, and I consider the Urban League a key partner in that coalition and other organizations, because we have to get the word out through our churches, social groups, that we in fact have a system in place in our community. We have capacity in our health centers. We would love to see more patients that have these conditions and concerns and do more testing. That's why we're there. We receive grants from the state and the federal government. About a year ago, we merged with Comprehensive Health Center. Comprehensive Health Center has a clinic at 286 Complex where Dr. Hood has his practice, at 3200 block of Ocean View and Elm Street downtown. We've recruited additional doctors, so we have capacity to take care of more patients. So we're looking to reach out to the community. That's why I was glad to be able to come today to tell you about what's happening in Washington. Is truly an opportunity. We have 400,000 uninsured residents in San Diego County, and our community is probably at least 100,000. So we have to work together to let people know that we're available, what our hours are at, and how they can access the system. And then I'll leave it, and then I'd like to open up the questions for Dr. Hood and myself.
So, Mr. Martinez, are you saying then if someone does not have any health coverage at all, they could still come to the comprehensive health locations?
Yes, that's what we're saying. We received a grant from the federal government. We're a federally qualified health center. It's called a FQHC. And that is to offset the cost for people without insurance or low income. What we do ask is that because the federal grant allows us to have a sliding fee scale, it's based on your income. For an individual or a family that's at federal poverty level, and for an individual it's $17,000 a year. For a family it's about $30,000. If they're at the federal poverty level or under, it costs $10 to see a doctor and get a lab test. And if our patients don't have the $10, they're always willing to sign a little agreement. Well, I'll pay you next month, and we always do that. Then we have other grants where there's no charge for it. It's based on a grant program. So we are sort of the core safety net in the area, and that's based on our funding from the federal government. That's why we receive the grants. Clovis?
Well, yeah, most of you guys know me, so I'm gonna harp on the same thing I harp on almost every time I'm at a meeting this time. But I do have a specific question. But first thing I want to say is I'm looking forward to a time when we have less discussion about managing chronic disease, which almost always comes up as the paradigm to preventing these diseases. And although I appreciate the information that's in here, this is a management document. It talks almost, except for avoiding drugs and alcohol, and tobacco, talks almost nothing about preventing the diseases that we're talking about managing, which is where the real cost of the system comes is we wait until people are sick before we begin to address their illnesses. And in light of that, I want to ask two questions. One, this seems to be kind of a distillation of 3200, I think.
Yes.
Yeah. And that's on the table as Congress has a bill that he's been working on for a long time. I want to ask these two questions. One, to what extent do these measures begin to address the root causes of disparities, which most of the research seems to point to being racism? And the second question is, it's great to move from second-class citizen to first-class citizen, but the first-class citizen in health in America is in pretty bad shape. And so it's kind of like going out of the fire into the frying pan. So to what extent do these measures begin to address the root causes of most of our chronic diseases, cardiovascular disease, malignant neoplastic hypertension? Is the focus on prevention, which will really reduce the cost when you reduce the expense of going to the doctor by not having to go to the doctor, or are they all focused on how to manage the chronic diseases we're creating from another source?
Just briefly, then I'll ask Dr. Hood to comment because he's our expert on disparities. But that does have a section here on wellness and prevention. And all the major bills that are being looked at in Congress do have an emphasis on preventative interventions applied early. In our primary care system, we emphasize the importance of primary care. That's really one of the essential callings of a primary care doctor, is to provide the acute episode that's needed, acute care, but also, once that's taken care of, emphasize the importance of prevention. And so all our primary care doctors do that. And that's what I was saying, that the doctor himself, because he's so busy, he needs a support team to do that. And that's why we're looking at nurse educators, physician assistants, lay educators, just another team that can provide that service for people that really are in need of it or are interested in it. In terms of disparities, you're right. I think the core root is the racism and the separation, the socioeconomic realities of our system. And we've been presenting the health disparities as a key building block for reform. It doesn't always percolate to the surface, and Dr. Hood can explain why.
First of all, you're right. And let me put it to you like this. If we're waiting for anything coming from any legislation to get to the core root of health disparities, we'll still have them 100 years from now. So if you're looking for an answer, it's you. It's us. And until we get that mentality, all that's going to come out of Washington and all that's going to come out of any legislation is an opportunity for us to tap into resources, programs that would allow us to formulate that into something that we feel will begin to get to the root causes. One of the reasons why we were trying to get this grant from the endowment was to do strategic planning. And one of the issues is, how do we deal with the root causes? I mean, there are some wonderful ideas out there. People are always talking about, we for 100 years have developed a sick care health system. And now you're demanding that that sick care health system become a wellness system. It ain't gonna happen overnight. So what you're saying is true, but and the reason why it's not gonna happen is because A, there's a lot of money in the sick care health system. And so it's gonna take grassroots ideas, programs that I think are going to come out of places like San Diego, New York, wherever they come from, and prove that they work. So we are hoping, as we move forward with this strategic planning, I think I was talking with Diane Moss, who is working on a food justice program for the area, trying to bring in farmers markets, things like that. Those are the types of things we want to tap into. But I'm telling you, it's going to be grassroots. So yes, every time we have these meetings, I hear that from you, and I'm going to continually tell you, we're waiting for you.
Dr. Hood, I was at the forum in July, and you made a comment that patients will have long-term and issues, and the question generally is, how much does it cost? And you were pointing out that that question cannot exist in the systems that we're going to. But my question then, and I didn't get a chance to ask it, was about, it seems that those folks that are against these healthcare initiatives have a lot to do with immigration and how it affects it. Can you speak a little bit about why that should not be a primary concern?
Well, I really think a lot of the issues that are being come up are really false issues. The whole issue of immigration, the whole issue of it costs too much. The whole issue is government take care of health plan. I mean, I sit and but what amazes me most is when I hear it coming from individuals who are arguing against their own interests. That blows my mind. I mean, I understand the pharmaceutical industry. I understand the health plan industry. I ain't angry at them. But when I see individuals out there who, I don't know, who they're listening to, and I shake my head, it makes no sense. Here is the reality. Costs. We already spend close to $2.5 trillion for our health care. Who is paying for that? 56% of the health care bill already is coming from your government. So by majority rules, it already is a single payer. It's just So we're paying for it there. Who's paying the other 40+%? The employers and us. I don't get it. We are already paying more for health care than we need to. So the system needs to be designed not only so that other folks can come in and get health care, but those of us who are paying for health care aren't looking at 10, 15, 20% increases in our premiums each year. I can't afford that, okay? And people think I'm rich, but I can't afford that, okay? I can't continue to do that for my employees, okay? They can't afford to continue to pay what they're paying. And what they do is, I don't know if you notice in healthcare, what they do is they shift the costs, okay? Even if they keep your premiums the same, they shifted more responsibility to the patient. You pay more for your drugs, you pay more for your co-pays. They'll take away some of your benefits. So you get not what you need, and you're still paying more. The system really, we're paying more than we need. The issue of the immigrants, the data that I've seen, they use very little of the health care dollar and probably pay more taxes than they use. So it is really a false issue. The government-run health plan, they don't want to give up the government health programs that they now have, but they don't want government in their business. So I don't know if I answered your question, but.
One more question.
Dr. Hood and Mr. Martinez, one of the things that you mentioned is access to providers you can trust. One of the biggest issues, of course, in the African-American community going to the doctor is that we've been the subject of many experiments that have gone on through time. So even with the new health reform coming, how are we going to ensure that we have healthcare providers in our communities that we can trust, that's going to give us the best information, that's going to treat us fair, that's the same healthcare that they're getting in La Jolla, we get it in Southeast San Diego.
One answer is we need to recruit from within our community students that want to be in the health professions. We have several doctors in our South Bay office that grew up in Nashville City and San Ysidro, went to Berkeley, went to medical school, and came back. We have a residency training program, so we encourage them in the local schools and colleges to consider medicine. We don't do that enough, but workforce diversity is a major issue that we really need to work on. Probably less than 5% of the graduating dentists and physicians and dental and medical schools are of minority populations. That's terrible. And it takes 10, 15 years for training for a physician or a dentist. So it's something that needs to be done, and it's sort of a long-term strategic thing that we have to do. Another way is that we have to recruit. I think by developing an innovative, really effective coalition in the community where we're doing things that are really cutting edge in terms of how we organize our care and the care that we deliver, that will attract physicians from other parts of the country or the state that are not in an environment where they can do clinical care and outreach work with the community or research. I think by building on our assets and letting the candidates out there who are considering a placement after the residency, have them come here to our community is one thing that we can work on.
And excellent question. We need to, what we call, increase the pipeline. And we need to have some type of incentives for folks to want to come to practice in areas like this. For many physicians, this is not an ideal place to want to come to practice. The average pay is lower in this area than elsewhere for a whole lot of reasons. One of the proposals we're putting together is a health empowerment zone in which areas of underserved, where there's a empowerment shortage area, will be designated an empowerment zone where physicians who do come here can come and have their loans paid off for the number of years that they work here. And in our area, it's not just primary care, it's also specialists that we have a hard time getting in here. So I think that's what I meant by taking the current legislation and crafting something that would specifically improve our needs in this area, and that's one of them.
That's a good idea. Very good idea.
Thank you both, Dr. Hood and Ed Martinez. Before you sit down, I think there needs to be what I call a call to action. So tell us what we should do. You know, call names out. The Urban League needs to do this. UAMIC needs to do that. And are there committees and councils that we can join to help you? Because we see you out here taking the lead, but we know that you can't do all the work yourself. So can you put us to work and give us some assignments of what we can do? Because you got some willing participants right here.
Yeah, good.
Well, Dr. Hood mentioned that we have a strategic planning grant at the California Endowment. It's been there about going on 2-3 months, and the initial and just recent feedback is that they really like it, they want to fund it, and that's all about what does the community, how do they perceive our needs, our unmet needs, what are the priorities? So that's an opportunity for all of us here to get together close. I think you raised a good question. You should be part of that. That should come up as one of the major issues for us to talk about and set there as a priority, because I think this is going to be a major effort. If we have a strategic plan that community supports and believes in, that's going to be the beginning for other innovative things to follow with funding from other foundations.
Yeah, and as we move forward, we've put together a community health advisory group, which is kind of very small. As these initiatives take off and we get grants, we plan on expanding that, and that's where you come in, because we're going to need somebody when we say we want to go to DHHS and get this area designated as a health empowerment zone, so we can do that. That's going to require the Urban League, your input, NAACP. When we start talking about what is the strategy, how do we develop programs that focus on preventive care? The best ideas are not going to come from me, Dr. Hood, or the administrators. It's going to come from folks who are here in the community. So we want to bring in the resources to kind of start those focus groups, bring in those individuals together. It's going to be a long-range strategy, but politically, what you can start doing is calling folks in Congress. Just let them know that people in this community are concerned about health reform, number one. When we had our forum, we handed this out, call to action, and it was the websites of various organizations that we felt if you contacted, let them know who you are. We're interested in what happens to health reform. We're working with some folks on a national scale. I don't know if it's going to happen. We're trying to get whatever the legislation is. You know how they have these amendments to all of these. We're trying to sneak something in there that points to us, whether that happens or not, so that when the legislation takes place and we come with our proposal, they'll say, that fits right into there. So we're working on all levels, but your voice needs to be heard now simply by calling Feinstein and your local folks. Just let them know that people in this community are concerned about health reform.
Perfect. Does everyone have a copy of the call to action?
I can get it to you.
Okay. Okay, perfect, perfect. Dr. Hood?
Thank you. Appreciate it.
Yeah, thank you very much.
Okay.
And we just have, before we let you go, we know it's a little past 9 o'clock. We just have one announcement. Dr. Wayman, did you want to mention your...